Have a very good morning. In ENT, we are talking about middle ear infections. In the first lecture, we were talking about hearing loss, various causes, common causes of hearing loss, congenital, acquired. Among acquired causes, acute suppurative otitis media, chronic suppurative otitis media, trauma, and various miscellaneous causes are very common. We'll talk about acute suppurative otitis media. Acute middle ear infections usually present with earache, hard of hearing, and later on ear discharge. Signs are almost the same. Initially, eardrum is congested, boggy, then there's perforation, and then purulent discharge from the affected ear. In chronic suppurative otitis media, germs are different. The disease is more troublesome. The symptoms are there is no pain, there is hard of hearing, and ear discharge. Sometimes ear discharge is foul smelling. Signs, mostly the two, hearing loss and ear discharge. Perforation almost always there. Chronic suppurative otitis media, as we were talking about, is two simple types, tubotympanic. Here the source of infection is in the nose or throat. If we clear the infection in the nose and throat, rhinitis, sinusitis, chronic allergies, chronic recurrent tonsillitis, then infection in the middle ear is usually immediately gone. In etiquental, the disease is confined to the etic region, the upper part of the middle ear, the topmost part of the middle ear that is affected. And here the disease has taken in various bad shapes like cholesteatoma and polyformation. And cholesteatoma is a very troublesome, eroding disease, invasive disease. It erodes whatsoever is coming in its way, so it leads to more complications, extracranial and intracranial. We may discuss the complications of acute and suppurative otitis media in different ways. And most commonly being asked, what are the possible complications of acute discharging ears or chronically discharging ears in a 6-year-old patient or in elderly? So we should know that middle ear is separated from the middle cranial fossa by a very thin bone called tegmen tympani. Posterior extension of tegmen tympani is also called tegmen entri. In very few individuals, this bone is absent, so infection can easily travel from the middle ear to the middle cranial fossa. Acute suppurative otitis media, once you're being asked, if asked for acute suppurative otitis media, chronic suppurative otitis media, its complications will always start saying extracranial or temporal complications or intracranial complications. And patient can have systemic spread of infective process, bacteremia, pyemia, septic abscesses, metastatic abscesses. So bacteremia, pyemia, septicemia, and metastatic abscesses are another series of complications caused by acute suppurative otitis media or chronic suppurative otitis media. Just to start with, upper respiratory tract infections always start with the viruses. Viruses could be DNA viruses or RNA viruses. Most common causes caused by upper respiratory tract infection, most common viruses are adenoviruses, rhinoviruses, even RNA viruses in the name of coronavirus now are coming into picture. In 1960s, very early years of 1960s, coronavirus was depicted as a common cause of upper respiratory tract infection among 20% individuals. If the disease persists for a few days, the bacteria came into picture and make the disease more troublesome and chronic. In upper respiratory tract infection, even in the nose and throat, the disease is caused by viruses in the form of common cold mostly or influenza in initially few days. After a week or so, the bacteria usually are implanted and grow, colonize, and leads to purulent discharge most often. And if the disease is further continued, the disease in an anaerobic situation where microaerophilic or low oxygen content in closed body cavities like middle ear, like interdental spaces, anaerobes, foul-smelling bacteria came into picture. So initially the viruses start in few days. After a week or so, bacteria, aerobes, gram-positive cocci, and bacilli usually come into picture and cause disease. If the disease further continued, then certainly it ends up with a bacterial infection in the form of anaerobic, that's foul-smelling infections. Acute suppurative otitis media is caused by common germs like Haemophilus influenzae and Streptococcus pneumoniae. H. influenzae is absolutely ubiquitous, very common, commonly cause of bacterial infections inside the human body among young children. Streptococcus pneumoniae, after 5 to 6 years, become more cumbersome infections. So, 3 bacteria which we should always remember and we should know a lot about: H. influenzae, Streptococcus pneumoniae, and uncommon bacteria are Branamella catarrhalis and new name is Meroxilla catarrhalis. So these 3 germs are common in acute suppurative otitis media. In chronic suppurative otitis media, gram-negative bacilli in the form of Pseudomonas aeruginosa, Staph aureus, and Bacteroides anaerobic germs in a various combinations. Patient can have germs on culture sensitivities, gram-negative bacilli, Pseudomonas, Klebsiella, Staph aureus, and Bacteroides. Sometimes a specific bacteria that come into picture in the tonsil, upper respiratory tract, and more common in middle ear. That is tuberculous otitis media. And if we continue to have antibiotics or steroid drops, then fungal chronic sinusitis can come into picture, which usually doesn't respond to common antibiotics, antibacterial agents. If we are asked for how you will investigate, how you will diagnose a case of chronic ear infection, acute ear infection, will certainly reply, will investigate while taking very fine history, good clinical examination, culture sensitivity of the pus that's coming from the ear, examination under microscope, various auditory tests, pure-tone audiometry, tympanometry, and if the patient is imbalanced, then vestibular tests will be conducted. And all the diseases inside the middle ear can nicely checked with the help of contrast CT scan or MRI. All these tests are absolutely necessary to make a very good diagnosis. If we find growth over there, mass over there in the form of cholesteatoma or polyp, then biopsy will ascertain the diagnosis. So how we'll investigate? That's always with the fine history, examination, culture sensitivity reports, examination under microscope, which is a highly useful in making diagnosis, because with microscopic examination gives finest possible look at micron level, not at millimeter level, so we can diagnose exactly is it a bacterial infection, is it a fungal infection, or it is something different story. How will manage acute suppurative otitis media? Acute suppurative otitis media, most of the patients are having earache or blocked ear or discharging ear. If the patient is having very severe infection, patient is unable to speak, unable to sleep, then intravenous antibiotics are usually required. Which antibiotic? Second generation cephalosporin, augmented penicillins, clarithromycin are the drugs of choice. If with antibiotics, orally or intravenous injections doesn't work in few days, 2 to 3 days, then laryngotomy, drainage of the pus from the middle ear, is called laryngotomy. Tympanocentesis, we just remove the pus from the middle ear while making very small hole in the middle ear along the floor, anteroinferiorly. Anteroinferior, very small perforation along the floor of the deep meatus. That works very well. In just few minutes, patient is totally, all bad symptoms like pain and blocked ear is gone. All these patients who are having acute suppurative otitis media certainly needs long-term follow-up. If you just control the infection and leave the patient as such, it has been seen that for 2 to 3 months, transudate, exudate, most of the germs are killed that persist in the middle ear. It's not drained by Eustachian tube. So follow-up of all these patients for 6 to 8 weeks, even sometimes for 3 months is required. Follow-up is an essential part of all these ailments. Management of chronic suppurative otitis media, again, antibiotics are different because here germs are Pseudomonas aeruginosa, Staph aureus, because beta-lactamase production is enormously more. It's quite different. It's plasmid-mediated and chromosomal-mediated. So our choice of antibiotics should be very strong against Pseudomonas and Staph aureus. These are the two germs, Staph aureus and Pseudomonas aeruginosa. In every specialty, Pseudomonas and Staph aureus are the most common serious complications in chronic abscesses. So our choice is third generation cephalosporin, new penicillins. Even sometimes if disease is not responding, we send immediately pus for culture sensitivity, and whatsoever is coming the result, even it's aminoglycoside, we have to select it. Antibiotics, if severe case, IV, if not, orally. DNA gyrase inhibitors are another choice. If the patient is having perforation, the disease has gone, ear is dry, but there's a big perforation in the ear, then it can be nicely grafted. The results are very heroic. 98% patients with the first attempt of grafting in the middle ear is always successful. So tympanoplasty, grafting of the eardrum, is highly. In chronic suppurative otitis media, patients are having cholesteatoma sometimes. The disease is called etiquentral type. Here, patient always need modified or radical mastectomy to clear off the cholesteatoma and polyp. Here, follow-up is for many years. For 5 to 6 years, repeatedly, patient has to come so that the disease is totally vanished, eradicated. If the patient is having perforation And here you can see round window through the perforation. Such perforations, once the infection is totally dry, once the infection in the middle ear is dry, it's dry since 2 to नहीं आपको डिसेबल किया हुआ मेरे वाला। ये उसी पे हो रही है। ओके ओके, थैंक यू वेरी मच। वो मसला है छोटा सा। थैंक यू वेरी मच। थैंक यू वेरी मच।
Welcome, sir.
Sorry for inconvenience. That's one drawback of connections and net. Middle ear infections can be acute suppurative otitis media or chronic suppurative otitis media. Complications we're talking about, I'll go a little bit. If the patient is having perforation in the eardrum that's dry, free of infection, it can be nicely grafted. If there's ossicle damage, it can be repaired. It's quite possible under vision of microscope because you're looking at things at a micron level. How disease spread from the middle ear in the surrounding area by direct spread or through venous channels like emissary veins, or it can go through various sutures which are not completely approximated, abutted in small children, and in young children there is chances of dehiscensis, absence of bones through round window and oval window. All these are channels. All these are channels for spread of infections. Disease can spread through veins, through direct channels, through sutures, and sometimes tegmen tympani, a very thin bone between middle ear and middle cranial fossa is absent. So every episode of infection in the middle ear is likely to have intracranial spread. My dear colleagues, we should remember that intracranial complications are very severe, having a high degree of morbidity, complications, and more chances of mortality also. All the infections inside the brain or in the surrounding structures come from ears and nose and sinuses. So every time we have to search for source of infection. For meningitis, brain abscess, we should look carefully into the ears, nose, sinuses. What are the complications of acute suppurative otitis media or chronic suppurative otitis media? Complications are the same. With good antibiotics, timely given antibiotics, incidence in acute infections is far less as compared to chronic suppurative otitis media. Acute is always associated with pain, discomfort, fever, so people take treatment timely. In chronic patients, in chronic suppurative otitis media, there is no pain. If one ear is normal, the other ear is discharging, only there is hearing loss. Patients don't take medicine timely. They don't come in contact with doctors, hospitals, then ultimately diagnosis is very late in the form of various complications. Extracranial complications are facial nerve paralysis, mastoiditis, various abscesses in and around the ears. If the abscess is along the tract of sternomastoid muscle, it's called Bizold abscess. If it's in the deep meatus, along the top, along the roof, that is called Lux abscess. If it is along the posterior belly of digastric, it is called Citelli's abscess. If the abscess is in the medial most inner part of petrous temporal bone, that along the foramen lacerum, the petrous bone on its medial most part is very spongy, very cellular. So there's easily infection can spread here and form an abscess that is called Pulitzer's abscess. There are so many abscesses called Bizold abscess, Lux abscess, and Citelli's abscess. Botitus in the form of Pulitzer abscess are simple spread of infection along petrous apex. In the form of Great Dingo syndrome, patient can present an infections inside the middle ear are called labyrinthitis. Once there's labyrinthitis, there's a huge, big, cumbersome symptoms like hearing loss. There is very severe imbalance in such patients. Intracranial complications are having higher degree of morbidity and mortality, more serious complications. Extradural abscess, subdural abscess, brain abscess, meningitis, lateral sinus thrombosis, autotic hydrocephalus. Last time we were going through, but again there was some problem, so I'm repeating these again. Extradural abscess is the most common complication intracranially. It is between the bone and the dura, bone of skull and dura mater. It is most commonly seen in the posterior part or in the posterior cranial fossa or in the middle cranial fossa, and evacuation of the abscess through general anesthesia, under general anesthesia is always necessary. Otherwise, patient can have multiple swellings here in the form of multiple abscesses over the mastoid region, behind the mastoid, or on the petrous temporal bone. Meningitis, very severe complications, sensorium is fine, patient is having neck stiffness, there's irritability, there's a photophobia, and the source of infection is almost always in upper respiratory tract. And patient needs most often third generation cephalosporins in mega doses, that 2 grams BD, that usually serve the purpose, and mostly patient is fine in a week or so. Subdural abscess or subdural empyema is another complication. Here, that particular part of the brain which is affected, the supplied area is having either irritative lesions or paralytic lesions, and if it continues, it can lead to damage in the long run. Most serious complication, most troublesome complication is abscess. Abscess can be in the posterior cranial fossa, in the cerebellum area, can be in the temporoparietal lobe. Such abscesses, if continues, build multiple foci, multiple loculi, like hydrated cyst, it can appear. So if it continues for a longer time, there's a headache, there's nausea, vomiting, visual loss, and contralateral, that particular area supplied by the brain is lost, then ultimately function of that particular area is also affected. Lateral sinus thrombosis, because it's an infective process, there's a very particular picket fence pattern. Such a fever comes in waves, goes away. Again, there's rigor, there's a lot of fever and sweating, rigors, and after some time it goes away. Autotic hydrocephalus, the episodes of vomiting, episodes of headache that persists over a period of many years, even after the thrombosis has occurred many years ago. There's a history of chronic ear discharge, there's history of headache that comes in waves. It's particularly there if the right ear is affected. Again, if the patient with CSM, acute suppurative otitis media, is having complications, and how he will investigate a complicated case, will always say clinical history, very fine examination. There is no match of diagnosing without a fine, precise clinical history. Always take fine clinical history. It's the success of medical science. Further clinical examination, if the pus is coming, any sort of fluid is coming, it will be sent to the lab for culture and sensitivity. If you feel it's a CSF due to breach of something like trauma, we'll send for beta-2 transferrin. Commonly being asked question, beta-2 transferrin is diagnostic for CSF if you feel that it's the clear fluid coming in the middle ear, post-trauma or due to some other reason, sometimes spontaneous without any, then beta-2 transferrin in that particular fluid will be diagnostic to see if it's a CSF. Culture and sensitivity will always make our life very easy. Examination under microscope, diagnosis most of the diseases of the middle ear in a very fine way. If the patient is having complications, extracranial or intracranial, certainly will go for CT scan or MRI. CT scan is a very good tool with contrast for infective process inside the bony chambers. In soft tissue like brain, MRI is far superior. Neurological tests like EEG, like electroneuronography in very severe patients can be very useful. Management of acute suppurative otitis media with complications, management of chronic suppurative otitis media with complications. All these patients who are having complicated ear, patient needs admission and treatment. IV line, IV Brenla is taken, IV antibiotics are being given. In acute suppurative otitis media, the germs are H. influenzae and pneumococcus. In chronic suppurative otitis media, we always focus on Pseudomonas, Staph aureus, and Bacteroides. All these patients are having multiple issues, brain involvement. If there's a meningitis, we always call for the physician to help us because neurophysicians are the best people to treat intracranial medically treated diseases. If the patient needs neurosurgical approach like abscess, then certainly neurosurgeon is the best person. First, the patient will be made free of disease, free of infection. Once the main infection, the life is stable, patient's abscess will be drained under general anesthesia. Eradication of extracranial disease with the help of cortical, modified, or radical mastectomies. All these patients not only need admission, they have to be kept in intensive care setup or high dependency units where patients' basic demands are being fulfilled. So all patients who are very serious and we have admitted, we have to decide the patient disease is elective, not very serious. It's a very serious disease like brain abscess, like meningitis. Such patients cannot be kept in the general ward. They will be kept in intensive care units so there are least complications. They are being looked after very nicely. HDU units are particularly helpful if we are having overburden of patients so that more number of nurses where frequent visits of doctors and nurses are required and desired. So long-term follow-up in all these patients who are having complications is required. Otherwise, recurrence is extremely common, especially if the patient is having immune compromised situation or patient is having some serious issues like diabetes mellitus. So chances of recurrence of such infection is very, very common. It's very common. So we have to take care of. So I'll just repeat it before ending it so that we can revise our ABC. So have a very good time with your family. We hope that you will be enjoying your studies at home. Take care, take extra care if you go away from home. Washing, masks, especially your very balanced diet. Acute suppurative otitis media, if the disease in the middle ear is confined and stays for a few weeks, it's called acute suppurative otitis media. Symptoms are very severe headache, fever, and later on ear discharge. Signs are there is purulent ear discharge in the middle ear. Patient can have congested eardrum, later on perforation, and in chronic suppurative otitis media, they are only hard of hearing and perforation. Chronic suppurative otitis media is two types: tuber-tympanic, where source of infection is confined inside the middle ear, and it has come through eustachian tube from tonsils or nose. If we eradicate the disease from the nose, which is in the form of rhinitis or sinusitis or chronic sore throat, usually the patient's middle ear is absolutely free of disease. In chronic suppurative otitis media etiquentral type, the disease is not dependent on upper respiratory tract infection. Here the disease has come or reached in the topmost part of the middle ear called etic, where there are main assembly of ossicles, where the ossicles are more damaged. Etic and the antrum. The disease could be in the form of cholesteatoma, could be in the form of polyp, could be in the form of rampant granulations, and could be even tuberculosis. All these complications can end up with further spread of disease. If we discuss complications of acute suppurative otitis media or chronic suppurative otitis media, these could be confined to extracranial area in the form of various facial nerve paralysis or abscesses, or patient can have spread of disease inside the cranium, inside the brain, that's having far higher degree of morbidity and mortality. Patient can spread the infection process from the middle ear into the blood circulation. Bacteremia, mere entry of bacteria into the human circulation. Or septicemia, further growth, multiplication of germs leading to symptoms. Pyemia, metastatic abscesses. So we should be familiar extracranial, intracranial, or systemic complications of acute suppurative otitis media or chronic suppurative otitis media. Infections start from viruses in the respiratory tract, later on followed by bacteria. In initial few days, viruses, adenovirus, rhinovirus, influenza virus, these reach from nose and throat into the middle ear through eustachian tube. So most often the start of the story, even in ear, is caused by few of the viruses. After a few days, the bacteria spread like anything on a fertile area where already inflamed. There's a lot of transudate, where the viruses have done their job partially. So after 1 to 2 weeks, bacterial infections come into picture, and if further it's continued for many weeks, anaerobic situation is reached, there's oxygen supply is far less in closed cavities, then foul-smelling bacteria, anaerobic bacteria come into the picture. In acute suppurative otitis media, H. influenzae, Streptococcus pneumoniae, and Bananamilla catarrhalis. There's a very good vaccine for H. influenzae type B called Hib vaccine. Those children who will be vaccinated by Hib vaccine, they will be having far better childhood, far less degree of infections. So vaccines are blessings. It should be a very good choice in every child. Staph aureus, Pseudomonas, and other gram-negative bacilli plus Bacteroides are multiple germs causing one disease most often. And sometimes we have tuberculosis, and if disease, we continue to have antibiotics, especially topical steroids and topical antibiotics. Fungal infections in the middle ear reach very easily. Investigations are very simple. Always will investigation doesn't mean only blood tests. We'll start from precise clinical history. We'll go for clinical examination. We'll always ask for culture and sensitivity of the air discharge. If you feel there's not passes a clear fluid coming from the nose or coming from the ear with exertion, and there is a doubt about CSF leak, we'll ask for beta-2 transferrin. Beta-2 transferrin in the clear fluid mean is a CSF. It comes spontaneously, it comes in traumas. Examination under microscope is a very strong, very useful tool for investigations for various disease picking inside the middle ear, and various vestibular tests, various auditory tests, hearing tests are always required. CT scan, MRI in all serious patients we do need. CT scan is very good for the bone and lesions inside, along the bone. MRI is very good tool for soft tissues like skin, subcutaneous tissues, thyroid, or especially for the brain.
Sorry to interrupt, just
acute suppurative otitis media.
1 minute left, sir.
Sorry?
Sir, sorry, just 1 minute left.
1 minute, okay. Okay, so thank you, my dear colleagues. We have gone through acute suppurative otitis media, chronic suppurative otitis media, selection of antibiotics. If you have any question, next time I'll give you the phone number. You can put your questions so that before coming to, if you can just remember one phone number, 0320 8407 313. 8407 313. Just give text message if you're having any query, any problem. Your feedback will be highly appreciated, and in next lecture, all your queries will be addressed. Then we'll go further. Thank you very much.